Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today, I'm going to talk a little bit about lipoprotein A. It's my favorite lipoprotein. I'm going to review for you guys a paper that was published late last year that dispelled a couple of the myths that have been prevalent about lipoprotein A. Primarily, the one being that diet and lifestyle don't have an effect on lipoprotein A levels. That's what I was taught traditionally, and that's what most papers out there will say, is that, especially diet in particular, doesn't have a huge impact on lipoprotein A. So what is lipoprotein A? For those of you guys that are not aware of this is something that, in my opinion, everybody should be screened for. And because it's extremely common. We're talking about like 20% of the world's population has elevated levels of lipoprotein A, which puts them, as I will show you here shortly, at significantly increased risk of developing cardiovascular disease, but also thrombosis, like deep venous thrombosis, pulmonary embolism, etc. So lipoprotein A is a sort of an abnormal form of LDL cholesterol. This is what it looks like here. I think that's kind of the best way to think about it. So it's this LDL particle, and then it has these two, this ApoA and ApoB component that are kind of bonded together with this disulfide bond. And again, this is something that so this is genetically mediated. And the traditional thought has been that whatever level of this that a person may have, if they have the gene for it, is entirely genetically mediated, and there's really not much that you can do to change that. Unlike other forms of dyslipidemia, where obviously like diet, lifestyle, etc., makes a huge difference. It was sort of thought like Lp(a), well, there's not much you can do about it. So, and that was kind of the argument maybe for not checking it in the past, because they're like, well, what does it matter? You can't do anything about it anyway. Well, that paradigm is changing. Not only do we have some medications that are in the pipeline now that potentially can radically lower lipoprotein A, it turns out that as I'm going to show you in this study, there actually might be some lifestyle things that you can do. And then some very interesting things, which we've known for a while, at least in the medical literature, from a hormonal standpoint, that can have like relatively profound effects on lipoprotein A, but are still, despite these things being out in the literature for like several decades, haven't really made their way into mainstream lipidology or mainstream cardiology yet. So we're going to talk about that. So, why do I care about this? Well, I have high lipoprotein A level. I inherited it from my father, and my dad has got horrible cardiovascular disease. Maybe I'll talk about that in a different talk, but I've got to give credit. He had a cardiologist well over 25 years ago that looked at the extent of my dad's coronary calcification. He had something called an eggshell aorta. You can look that up and see what it looks like. He had a very calcified aortic valve, and the extent of his disease was far in excess of what it should be if you just looked at his LDL and HDL levels, which really weren't that bad. Anyway, this very sharp cardiologist checked a lipoprotein A level on him. It was markedly elevated. Even then we knew this was an autosomal dominant trait, so there was a 50% chance that I would have it. Sure enough, I did. So I've known about my elevated lipoprotein A levels since, I don't know, probably my late 20s, when I was in medical school and residency. And using some of the things I'm going to talk about in this paper, I've been able to cut it in half, so that my Lp(a) level now is actually right at the upper limit of the normal range, when it was actually like almost double that, in the past. So I guess time will tell if that makes a big difference for me long term. So anyway, so the interesting thing about lipoprotein A, this is a little bit of an aside thing. If it's universally harmful, you always got to wonder, like, well, why is it so prevalent? Well, there's some theories that it actually, evolutionarily might have been actually beneficial, like in Paleolithic times, because it embeds itself in the artery wall and because it's prothrombotic. It's thought that it might, mitigate, or lower your chance of dying of like hemorrhage. So women in childbirth, even today, can die from postpartum hemorrhages. If you get your leg bit by a saber-toothed tiger back in the day, you certainly, risk bleeding to death. And, it's possible that high lipoprotein A levels could give you just enough of an advantage that, you know, maybe you would survive that event. So Linus Pauling seemed to think that it also helped mitigate the effects of vitamin C deficiency, like scurvy, because of its ability to kind of reinforce arterial walls and you know, small capillaries and things like that, which, you know, can become very friable and fragile with something like scurvy. So anyway, it's kind of interesting. You always got to wonder why something that's pathological is so common in the human population. It's, you know, sometimes it's because at one point in our history it was actually an advantage, and now that we're living longer, it's a disadvantage. So just it's kind of an interesting thought experiment. My approach with lipoprotein A, and I think this is eventually going to catch on, I screen everybody for this. If it hasn't been done before they come and see me. And, you know, because this is an autosomal dominant genetic condition, if you check it and it's normal, you never have to check it again. Like, you're good. You know, worry about the other aspects of your cardiovascular health, your other risk factors, but you really don't have to worry about it's not going to get elevated like out of nowhere. But if it is high, you know, at least you know, and then you can not only get more aggressive with your other cardiovascular risk factors, but potentially incorporate some of the things I'm going to talk about today, in addition to some of these potentially more promising prescription medications which are coming down the pipeline. So anyway, I think it's important. I strongly encourage you guys, if you have not had a lipoprotein A level done, next time you go get your cholesterol done at your family clinic, wherever the case may be, ask them to throw on a lipoprotein A, you know, because it might end up being useful. So why do I care about it, other than for myself, but for my patients? This is really interesting. So clearly, elevated lipoprotein A levels are associated with marked increase in cardiovascular disease. So coronary artery stenosis, you know, 5-fold increase. MI, 3 to 4-fold increase. Valvular aortic stenosis, 3-fold increase. And then, you know, stroke, heart failure, and then all-cause mortality. All of these things are higher in people that have high lipoprotein A. So, you know, it's potentially a big deal. And you know, again, that's why I think it's worth screening for it, especially now. Like I said, I keep saying it, but you know, we're going to have some better therapies down the road, you know, to address this. So this is the paper we're going to talk about today, among a few others, but this is the primary paper. So this is from the journal Atherosclerosis. It was just published this last May in 2022. And it's called Non-Genetic Influences on Lipoprotein A. And they talk about a number of different things in here. The ones we're going to touch on mostly are diet and then hormones. So, and I like this paper's great because it, you know, I love papers that show that the things that we've learned traditionally in medicine are incorrect. And this is good. This is one of them. So let's cut to the chase here. What does it say about diet? Well, it turns out that so saturated fat, which typically doesn't do wonders for your lipid panel in general, saturated fat intake actually lowers lipoprotein A levels. So you know, that's not a reason to go out and like drink bacon grease and eat, you know, raw meat and all that stuff, and because you know that's going to affect your LDL. It can have some other effects as well, but it will it will lower lipoprotein A. This is a really interesting article here. So this is the Omni Heart Trial, and Omni Heart Trial, they looked at specifically the DASH diet, which is very, very popular. So the DASH diet is a very low fat, higher carbohydrate, you know, low to moderate protein diet. It's very low in sodium. It's used to treat hypertension, and it's commonly recommended for people with cardiovascular disease. And I'm not going to weigh into the pros and cons of the DASH diet. You know, certainly if you want to give it a go, or if your cardiologist recommends it, I don't have a problem with that. But what they did find is that this particular diet, because it was so low in fat, it actually raised lipoprotein A levels. And, you know, like not massively, but like between 8 and 18%. And that's within just the first 6 weeks. So it would have been interesting to see, you know, if they took this longer, you know, what, you know, would it have plateaued at 8 to 18, or would it continue to rise? So that's not a reason not to do this diet. But if you otherwise have a pretty decent lipid panel, but lipoprotein A is an issue for you, A diet such as this with very low amounts of fat, maybe that's not the best diet for you. Maybe a bit more of a Mediterranean diet with, instead of perhaps so much saturated fat, you could also have like mono and polyunsaturated fat. So interestingly enough, according to the paper I was showing you earlier, so saturated fat definitely lowers lipoprotein A, but mono and polyunsaturated fats do tend to raise it, but just a little bit, like not enough, they said, to be statistically significant. So obviously, I still think that replacing saturated fat for the most part with mono and polyunsaturated fat is still, overall, that's obviously a viable nutritional strategy, and in the long run, is probably better for you than eating tons and tons of saturated fat. Okay, I was keeping that in moderation. The important thing to say here too with this diet stuff is, like, you have to kind of keep this in context. There's a lot of things that go into the development of cardiovascular disease and atherosclerosis. Lipoprotein A is just one of them. Okay, so if you have a high lipoprotein A level, I don't want you to get like laser focused on that and ignore your insulin resistance, ignore hypertension, vascular dysfunction, cardiovascular inflammation, all these other things, your LDL, particle size, and all this sort of stuff. You still need to not put your blinders on and just focus on lipoprotein A. You need to address all those other things. And until these other like really potent LP little a lowering medications come around, and if they end up panning out, until that happens, that, in my opinion, is still your best strategy for addressing a high lipoprotein A level, is minimizing all of your other cardiovascular risk factors as much as possible. So especially like ApoB and blood pressure and insulin resistance, all those things are critically important. They're just even more important if you have a high LP little a level. Okay, so I just want to say that, this talks about lipoprotein A, but I don't want you to focus in just on that. So what's interesting about this paper, in my opinion, is that, traditionally, and even currently on the American Academy of Cardiology website, they say that diet has no influence on lipoprotein A levels, but, it looks like it does. Now, granted, it's not a huge difference, but, an 18% difference in LP little a, that might be clinically significant. So the other thing that they do mention in this paper that is also important, I think at this point we all hopefully know that trans fats are absolutely terrible for you in so many different ways, but they markedly increase LP little a levels. So saturated fat will lower it, but trans fats in particular are terrible for you in so many different ways, but they can raise LP little a levels by, like they said, up to 73%. So you should have 0 grams of trans fat in your diet if at all possible, because that will definitely, that's a big one. 73% is impressive. So now, what about alcohol? Turns out alcohol doesn't have much of an effect. I don't recommend that you consume alcohol, especially if you're doing it for cardiovascular health. I think that's been debunked, in my opinion. And if you want to have a cocktail every now and then, by all means, for social situations and things like that, go ahead and do it. But if you're having a drink of alcohol every day, thinking that you're going to benefit yourself from a cardiovascular standpoint, at this point, I don't think the data is there to support that. So, and it certainly has no effect whatsoever on your lipoprotein A. I really was hoping this article would say something about exercise being beneficial. Turns out no significant effect, whether it's resistance training, cardiovascular training, but it's pretty clear that like improving your cardiorespiratory fitness, improving your muscle mass and weight training, whether it's low intensity, high intensity exercise, doesn't matter. Not a huge effect on lipoprotein A, unfortunately, which doesn't mean that you shouldn't do it. You need to do it, but just don't expect major changes in lipoprotein A. Okay, so here's where it gets kind of interesting. So hormones. Again, I've actually known about this for a long time because I remember reading these papers a long time ago, but I wanted to bring them to light to you because I do think they're important. I went to the American College of Cardiology website. They have a really good article there. It's called Lp(a) in Clinical Practice, and you can go check it out. It's well written. It gives you like a really good summary of lipoprotein A. But there was a quote in there that stood out to me, and it said, quote, "Hormone replacement therapy reduces lipoprotein A," which is true. I'm going to show you that, comma, "but its use is limited by the excess increase in adverse events." I'm going to refer you to my last video where I kind of fact-checked a female cardiologist that was talking about TRT and was just perpetuating all these myths about adverse effects, and saying that it was essentially like hypogonadism in men is just made-up condition. So unfortunately, some of these myths are just, it's going to take a while for them to go away. But clearly, if you know anything about hormone replacement, and if it's done properly, judiciously, under the supervision of a knowledgeable physician, adverse events from hormone replacement therapy, especially in the realm of cardiovascular disease, are extremely low. In fact, it's quite the opposite. You're likely to improve your cardiovascular risk profile if you have some of these hormonal deficiencies addressed. So I'm going to talk about that here in just a second. So testosterone actually has a fairly profound effect on lowering lipoprotein A. So this is an article here from the journal Atherosclerosis. It's an older one, and a lot of this stuff is kind of buried. This one's from 1996 in April. And they put men who, they didn't even have hypogonadism. These were otherwise healthy men. And they put them on, so like pretty generous dose. So 200 milligrams of testosterone. They used N-enthate. There's no reason to think that either cypionate or propionate or even undecanoate would have any different effect. They did 200 milligrams a week, and they found that these guys had a fairly, I consider it a fairly impressive drop in their lipoprotein A levels. And although it was highly variable. So the take home, there's two take home messages here. One, if you had a normal Lp(a) level, it didn't do squat for you. So, don't get on testosterone if you haven't, unless it's for other reasons. But if you're trying to lower your Lp(a) even further when it's still in the normal range, don't expect testosterone to have a huge effect on that. But if you do have high Lp(a) levels, they noticed in their subjects anywhere between 25 to 59% reduction in lipoprotein A, which is actually, that's fairly significant. And it's better than all of the medications, for the most part, that are currently available. Things like niacin, fibrates, and even like PCSK9 inhibitors. Now, not as good potentially as some of these newer things in the pipeline, which I'm not going to talk about today, but a 25 to 59% reduction is pretty darn good. And that's just with, granted a generous amount of testosterone, but still within what many clinicians would consider the TRT realm. Okay. Now, for the sake of time, I didn't include these other studies, but there are some other studies looking at like male bodybuilders, and they were using like way super physiologic doses of not just testosterone, but other anabolic steroids. And they also had like fairly dramatic drops in their lipoprotein A. Not surprisingly though, the rest of their lipid panels looked terrible because they were abusing anabolic steroids. So they all had low HDL, they all had unfavorable changes in LDL, and that's not surprising. But these guys in this study did not, but they did benefit in terms of lowering their lipoprotein A levels. So the question I had when I saw this article initially was like, okay, is this a direct effect of the androgen, of the testosterone itself, or is it the aromatization of testosterone into estradiol that's having that effect? And so I'm going to show you a couple of papers that help answer that a little bit. We've known for a while, obviously, that in women, estradiol has beneficial cardiovascular effects and can make lipid panels improve. It does lower premenopausal women tend to have lower lipoprotein A levels until they hit menopause, and then their levels go up, similar to the men, and that's presumed to be related to their elevated estradiol levels. So this is a study, hormonal regulation of serum lipoprotein A levels It's in the Journal of Clinical Investigation back in, this is an old one, 1992. So what they did is they took elderly men with metastatic prostate cancer, and they randomized them to either have orchiectomy, so they were castrated, or to receive oral plus or minus intramuscular estrogen, estradiol, and with the goal of like lowering their testosterone levels as low as possible, and basically seeing what would happen to their lipid panel, specifically their lipoprotein A. So interestingly enough, the men that were given estradiol, either orally or intramuscularly, they had about a 50% drop in their lipoprotein A levels on average. The men who just were castrated and didn't get anything, both groups dropped their testosterone significantly, but obviously the castrated group also had a drop in their estrogen levels because estrogen comes from testosterone. Well, they had a 20% increase in their lipoprotein A levels. So it's pretty clear, obviously in women, estradiol is beneficial for lipoprotein A, but according to this study and a number of other ones that I did not include in here, estradiol has a positive effect in terms of lipoprotein A in men as well. So what does that mean for you guys on TRT? It means, for God's sakes, don't take an anastrozole. Do not block the conversion of testosterone to estradiol. There's so many other reasons not to do that, but this is just one more. If you have a high lipoprotein A level, you can expect your lipoprotein A level to probably increase if you start blocking estradiol. So yet another reason not to do it. But okay, so that's it's the estrogen component, right, that seems to be helping. But it turns out that probably the testosterone component does too. I couldn't find any studies that looked just at that's a hard study to do, and I couldn't find anything that looked just at testosterone. But there are studies looking at other androgens that do not aromatize or don't aromatize like to a significant extent, and seeing if they affected lipoprotein A. So this is one here. Nandrolone decanoate reduces serum lipoprotein A levels in hemodialysis patients. So, take it for what it is. I mean, this is in a chronically ill subpopulation with chronic kidney disease, bad enough that they need dialysis. So these guys are not healthy at baseline. But they put these guys on nandrolone, and they had a fairly significant drop in their lipoprotein A levels. So it looks like, according to this study, which by the way is in the American Journal of Kidney Disease back from 1997, so well-respected nephrology journal, they on average dropped their lipoprotein A levels from a baseline of 19.8 milligrams per deciliter, and then by month number 6 it had dropped down to 7.1. So that's a big drop, like way more than half, almost a threefold drop. So whether this had any long-term effect on their morbidity and mortality, they didn't comment on that. People with dialysis have abbreviated lifespans, as you can imagine. They've got a lot of other reasons, to die early. But what this tells me with guys that are on TRT, if you can extrapolate this, is that there's probably a combined effect. The testosterone itself, I suspect, lowers lipoprotein A, and then then you get added benefit from the aromatization of testosterone into estradiol that also further significantly lowers lipoprotein A. So again, don't take an anastrozole. Okay, moving on. Thyroid. So treating hypothyroidism is important for a lot of different reasons, but it will lower lipoprotein A. So and this is regardless of how severe your hypothyroidism is. So overt hypothyroidism, where you have demonstrably low T4 and probably T3 with an elevated TSH, clearly benefits from supplementation or replacement with levothyroxine. And unfortunately, all the studies I could find, they're all with levothyroxine, T4. I didn't see any that had they used a combination product or used T3 alone. Presumably, there's going to be a similar effect, but I don't know. I just couldn't find any studies on that. But the decrease it's modest. So they said an average of 5.6 milligram per deciliter decrease. So that's not super impressive, But it's better than nothing, and I think it's still worth potentially looking at. Interestingly enough, people with subclinical hypothyroidism, which means elevated TSH, but normal free T4, with or without symptoms, also seem to benefit from this. They got a modest decrease in their lipoprotein A level. Not quite as much as people obviously with overt hypothyroidism, but they still seem to benefit as well. So I bring this up because if you have, let's say you have subclinical hypothyroidism, and your lipid panel is maybe not quite where it should be, you have an elevated lipoprotein A level, but let's say you otherwise feel okay. This potentially could be an indication for your endocrinologist or your primary care physician to initiate treatment with thyroid hormone. Because if you look at the formal endocrine society guidelines for subclinical hypothyroidism, they don't necessarily recommend treating that unless the TSH gets to a certain level or they start developing like classic hypothyroid symptoms. So, but if you have a markedly elevated lipoprotein A level, maybe your LDL is not as good as it should be, but you otherwise feel okay, you might be able to make a case, or there could be a case, for starting thyroid replacement in that situation. So I just throw that out there for you guys, that maybe in that boat you can have that conversation with your doctor. So okay, let's finish up with growth hormone. Everybody loves growth hormone. I don't really know why, but they do. So it turns out that growth hormone makes lipoprotein A lot worse. Yeah, sorry. You would think it wouldn't, but it does. So all the studies I looked at, they were with adults who had like genuine adult onset pituitary insufficiency for a variety of reasons. So, this wasn't growth hormone that was being used for performance enhancing, for its performance enhancing effects, or for like quote anti-aging. These were people that were genuinely growth hormone deficient. And it turns out that they raised their lipoprotein A levels anywhere between 25, in some cases up to 100%. So, like, not an insignificant amount. So, I'm not saying, like, clearly, I think if you genuinely have growth hormone deficiency, I would not take it because of its LP little a raising issues, no matter how high my LP little a was, because I think, and I suspect, that the benefits are going to outweigh the risks in that situation. But if you want to take it for quote anti-aging purposes and you have a very high lipoprotein A level that's not responding to other modalities, I might think twice about this. Like, I don't have any plans to get on growth hormone at any point, unless I become overtly deficient. I'm just not that impressed with growth hormone. I know there's people out there that disagree with me, and that's completely fine. I don't think the bang is worth the buck with it, but I've been able to lower my lipoprotein A levels. I was digging around to try to find my original labs for you guys, but I couldn't find them. But I can tell you what happened is I've been able to lower my lipoprotein A levels. They were, at one point, they were twice the upper limit of normal, and with testosterone replacement without an anastrozole, and I tend to follow a lower carbohydrate, higher poly and monounsaturated fat diet. The combination of those two, I've been able to get my lipoprotein A levels down to like right at the upper limit of the normal range. So, I consider that to be significant. But probably more importantly, I have really kept a close eye on all of my other cardiovascular risk factors. Try to keep my apolipoprotein B down. I keep close tabs on my blood pressure. Thankfully, that's been good. My high sensitivity CRP is like undetectable. So, all these other things I really, really, really focus on, and I'm extra diligent on those because I know I've got this lipoprotein A issue. But I did all those things before I started on testosterone, and it was really the testosterone therapy that brought the lipoprotein A level to the point where it is now, because really nothing else has changed. I always, I had a pretty darn healthy lifestyle. before I started on TRT, close to 10 years ago. So, okay, guys, that's all I got for you today. Lipoprotein A, if you haven't been checked for it, ask your doctor. It is a big deal. There are some lifestyle things that you can do according to this paper. So make sure you address hormonal deficiencies, specifically testosterone and thyroid to a lesser extent. Maybe don't take growth hormone unless you really, really need it. And maybe, stick to a slightly lower carbohydrate diet with a little bit more fat in it to get that little extra benefit in terms of lowering lipoprotein A. But remember, keep this in context. Lipoprotein A is just one factor in the whole, cardiovascular disease picture, and don't ignore the other ones just because you've got laser focus on lipoprotein A. So, all right, guys, that's all I got for you. I will catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.